So our next speaker that we have, hopefully should be unmuting herself as we speak and showing us her camera. Oh, there she is. Hello, Becky. I called her Rebecca.
You don't like Rebecca though, do you?
I don't like Rebecca, no.
She doesn't like Rebecca, so we have to call her Becky. So we had a few questions that we have prepared for you. I'm just trying to see if
get to know the team as well as a kind of conferencey type thing, isn't it? So yeah. We're asking lots of silly questions for everybody. We haven't singled you out.
No, we haven't. So I think Beth had one first.
Okay, so a really hard question for you, because we know you're super, super clever. What is your favourite colour of eyes? We're guessing that everybody knows that we call Becky the Queen of Eyes.
Yeah, she's our resident ophthalmology person.
Research yourself.
So I have brown eyes, but I'm the only one in my family who actually has brown eyes. Everybody else has blue eyes.
Now.
I always remember being in a biology lesson and the biology teacher saying that if both your parents have blue eyes, you can't have a child with brown eyes. And I was sat there going, are you trying to tell me that my parents are not my parents? But I have to say that I really do love blue eyes. Piercing blue eyes.
You can get some really nice ones, can't you?
Yes.
There's some good eyes, piercing blue eyes. Cool. A few people have said, can you introduce yourself, Becky? And we will ask you to do that because we always get your title wrong. It's so long. So we'll let Becky do it. She's got many, many hats. And like I said, we just call her the Queen of Eyes. So we will let Becky explain what her titles are.
Yeah, so I'm a senior research officer in the Diabetes Research Group down in Swansea University. So I specifically look after retinopathy related projects because my background is in retinopathy screening. So I spent 4 years in the Welsh Diabetic Eye Screening Service, 2 years as a grader and then 2 years as a senior grader. So I was responsible for training up all of the new graders underneath me. And I've also spent a year in the Gloucester Eye Service as well. So lots of screening experience. And then my PhD was in screening intervals. So I'm a senior research officer, so I look after all the retinopathy projects, but I also am the Informatics Lead for the group. So I look after all of the big data diabetes projects that we have ongoing in Swansea. And then I'm a program lead for the MSc Diabetes Practice course, which is for healthcare professionals, which Beth is one of my current
very good. Yeah, it is really good course. So yeah, Becky's great on that. So you're the actual person that once people have had their eyes, like retinal screening done, you look at the eye pictures, the eyeballs.
Yes.
And look at the
4 years in a very dark room staring at.
Yeah, they are really dark, aren't they?
Yes.
Yeah, I've been in one and it is quite like you're a little bat. Just sit all day in a little dark room.
Yeah, we had the blackout blinds and then blackout curtains on all of the windows.
Wow. That's so crazy, especially in the winter. I mean, it's bad enough with the English weather, isn't it? But then going into a dark room all day.
Yeah. Left for work in the dark, left work in the dark, worked all day in the dark.
Work in the dark.
We best get on to our other question. So who was your favourite teacher? We're just bringing this up because you work in a uni. And we were like, we're gonna, find out who inspired you to go and work in the uni. Who's your favourite teacher?
So in school, it would have been my biology teacher, mainly because she, after my A-levels, so before I sat my A-levels, about 2 weeks before, I broke my right arm and I'm right-handed. And so my A-levels, I had to actually dictate all of my responses and somebody else had to write down all the answers for me, which is quite difficult in a chemistry exam when you have to explain where all the bonds go for all the molecules. And
imagine that being your job, though, just writing down people's exams. Bad enough having to do them yourself.
Yes, yeah. So I didn't do very well in my A-levels. So she gave me my A-level results, and I broke down into tears, and she put her arms around me and said, "It's going to be okay. You can still go to uni. Don't worry. It'll be sorted." But I think the person who has inspired me the most is probably he used to be the clinical director at the retinopathy screening service. So when I joined there, it was Professor David Owens, and he put his arms around me and said, "Come and do a PhD with me. You can do this." And where is it now? 12 years later, I'm still working with him, and he's still inspiring me now. So
that's so nice.
We'll let you get on with your slides. If you can share your screen, otherwise we're going to run out of time.
Yeah, we've got loads of questions coming in for you already, so we'll do those at the end. But if you've got questions for Becky, just put them up, and we'll ask at the end if we've got time. And we meant to say, if you're tweeting us or you want any questions answered from there, use the hashtag 101downloaded, and then we can ask those. So,
brilliant.
Okay, so I'm going to start with how diabetes affects your eyes. So I'm going to take you through a little bit about screening and grading of retinal images, and just maybe explaining a little bit about what the results letters, those really scary, horrible results letters mean, and hopefully putting your mind at rest that there are stuff out there you can do to limit your risk of developing retinopathy. So when we did our very first tutorial session on Diabetes 101, I asked all of our followers to tell me what the first thing they thought of when we said the words diabetic retinopathy. And I think the biggest thing that stands out from this word cloud that we put together for me was fear. It is so scary. Anybody who's at risk of losing their sight, I mean, it is a big fear factor. But I think a lot of the fear comes from the way you've been told about retinopathy in the past, and maybe a lack of understanding of, fear of the unknown, I suppose. You can't see what's going on, and so you don't know what's happening. So hopefully I can demystify some of these things for you. So before I go into retinopathy, I just wanted to familiarise everybody with what the important features of the eye are. So this is a retinal image. So this is the very back of your eye. And this is what screening takes and what they look for. We've got the optic disc here. So this is where all of your blood vessels and all the nerves, where they enter and leave the eye. It is actually a blind spot, so there's no vision on the optic disc itself. And then we have a really important area of the eye. So we have the fovea. Now, this is really important because it's responsible for all of your central vision, all your fine detail, all of your ability to read and see letters and numbers. It's all because of this small dark area here, the fovea. And because of its importance, we put a ring around the outside of it, so that this is then deemed the macular area. And the importance of the macular area will become apparent when I talk through about retinopathy. So these are two images that we take in England and Wales. So we take a macular-centred image, which is this one on the left, so that we can get a good view of what's going on around the fovea. But because this is the smallest part, it's a small part of the eye, the retina is quite large in the eye. We also like to take a nasal view as well, so that we can see a little bit more of what's going on in the periphery. Scotland is slightly different to England and Wales because they only take this first retinal image, the macular image. They don't actually take the nasal, and that's why they can get away with using less dilating drops. So we use the dilating drops because once the flash of the camera goes off the first time, the pupils get really small, and it means that we struggle to take the second image, but we would also struggle to take images of the second eye as well. So we use dilating drops to try and keep the pupils open so that we can get nice, clear images for the graders. So clear images are really important for grading retinopathy because we are looking for really small changes in the eyes, and as graders, we hate missing anything. We hate missing things in the eyes, so because we see that it's something that we can tell you about, we can inform you of, and then there's changes that you can make to help reverse it. So you may not believe me because it's really small, but in this first image here on the left, there is a microaneurysm just here above the fovea. So all of these images, all four of these are background retinopathy. They're all deemed background retinopathy. It's a wide-ranging category, so it can go from anywhere from a single microaneurysm to less than 8 blot hemorrhages. So we're talking about these here are blot hemorrhages, and in this one out here. So these are bleeding, so the vessels are now leaking and are not supplying blood around the rest of the eye. And we also get exudates. So these are fatty deposits, which are also leaking out of the retina, out of the vessels in the retina. So it's quite a wide category. So if you get your screening result back and it says R1, background diabetic retinopathy, you're somewhere in this region. You would be rescreened in 12 months, and the advice then is glycemic management, blood pressure, and your cholesterol, which are really important. This category then, so we're looking for retinopathy, but we're also looking for maculopathy. So M1 is maculopathy. Now, maculopathy really just is retinopathy lesions that have developed within that circle macular area that I pointed out in the first slide. So the exudates here in this image are within that circle, and so that is what makes it maculopathy. This is really important because we only have 2D images in screening, so we can't tell whether there's any thickening or any fluid leakage in these images. So we would say there's probably, for this one here, there's probably some fluid leakage in the middle here that could require some treatment. But because we can't tell that, we have to send anybody with a maculopathy grade into ophthalmology so that they can take another photograph, but this would measure the thickness of the retina, and that determines whether or not you need treatment. It's really important to know that about 60 to 70% of our maculopathy referrals into ophthalmology would be discharged after that first screening, first ophthalmology appointment where they take that image, because there's no thickening and there's no treatment required. So you would just come back to the screening service and you would be screened regularly again then. I wouldn't expect anybody to realise that there's any sight changes in this grade of maculopathy, but by the time it's out at this size, because of the proximity to the fovea, I would imagine that there would be some sight changes, so it would be symptomatic by that point. So the next stage of diabetic retinopathy is pre-proliferative. So this is an R2 grade. This is a stage now where it's slightly further on from the background retinopathy, but we're still not at a stage where we would need any treatment. But because you would need more regular follow-up, the screening service would have to refer you into ophthalmology for the monitoring at this point. So pre-proliferative retinopathy has multiple blot hemorrhages. So this is more than 8 of these bleeding hemorrhages. We'd also get what we call cotton wool spots. So these are these white fluffy areas here on the retina. So these areas are where, because the vessels are leaking out into the retina, these areas are not being supplied with oxygen, so they get what's termed ischemic. So this is just a progression on from the background. It's not quite at the proliferative level. This then leads us into the proliferative retinopathy stage, which is R3. This stage would need treatment. So because of those cotton wool spot areas, the eye, I think, is quite cool because it tries to resupply these areas with blood. So it grows its own new vessels to resupply the area. But these vessels are really weak and friable, and they break and they bleed. It's when they break and bleed, that's when you start noticing sight changes. So at this point here, there may not be any noticeable difference in your vision, but this is when we would like to treat you. By the time it gets to this stage, where these are pre-retinal hemorrhages, so the new vessels, if you can imagine like a 3D, this is a 3D object, obviously, and the new vessels are growing out of the eye, off the back of the retina, and into the vitreous layer. And I've always been told to describe these as if you could imagine like a coral reef, and the coral, the fronds of the coral growing out into the sea. But these break and they bleed, and then we get these pre-retinal hemorrhages. So these would then, you would notice these in your vision, you'd have dark spots in your vision. If they carry on bleeding, they bleed into the vitreous itself, and you get a vitreous hemorrhage, which is in this eye. So treatment, we would like to treat at this stage or even slightly earlier than this. We don't want it to get to this stage because it would need more treatment than the earlier stages. So why do we screen for retinopathy? So I've already said we're aiming to detect the sight-threatening lesions at their earliest possible stage when the treatment is most effective. So this is usually before you notice any change in your vision. And the earlier we treat, the less treatment you'll need. So what's the risk of progression of retinopathy? So if you've got no retinopathy in either of your eyes, there's a 1 in 50 chance of referable retinopathy developing within the next 3 years. So it's a really low risk. If you get a screening appointment result that says you've got nothing in either eye, then you have a low risk of developing a sight-threatening level of retinopathy within the next 3 years. And this referable category is your pre-proliferatives, your proliferatives, and the maculopathy category. If you develop background retinopathy in one eye, your chance increases of developing referable retinopathy within the next 3 years. So you have a 1 in 20 chance. But if you develop background retinopathy in both eyes, this increases to 1 in 4. So 1 in 4 chance of developing a referable retinopathy within 3 years. So what are the risk factors for retinopathy? So there are things, like Partha said, there's things you can change and there's things that you can't change. So if you concentrate on the things that you can change, these are lowering glucose levels, lowering blood pressure, and lowering cholesterol. These are things that you can actively do, and they're the cornerstones in the management and prevention of diabetic retinopathy. The things you can't change how long you've had your diabetes for. Ethnicity, there is research to say that South Asians, Latino Americans, indigenous populations are all at greater risk of developing retinopathy. Pregnancy is a really important one. If you do become pregnant, you should have more frequent screening. So if you have diabetes, you become pregnant. If you've had screening within the previous 3 months prior to pregnancy, we take that screening result. If not, then you would need to be screened within your first trimester to give us a baseline reading for what your screening needs to be going forward. If there's no retinopathy in that baseline screening, then you would have a further screening appointment at 28 weeks and then at 3 months postpartum. If there's background retinopathy at that screening event, at the first one, you would need a follow-up screening at 16 to 20 weeks, at 28 weeks, and then again at 3 months postpartum. If there's referable retinopathy in the eyes at that first screening, you would be referred into ophthalmology, and they would then decide your follow-up, but they would also follow you up for 6 months postpartum as well. Puberty can also cause changes in the eyes due to all the different hormones being released, and genes play an important role in diabetic retinopathy. So what's the risk of progression of retinopathy? So this graph is always quite scary because, retinopathy is developing, but the red line here indicates type 1 diabetes. The blue line is type 2 diabetes. And these two solid lines are for any retinopathy developing, and the dotted lines then are for referable retinopathy developing. So after about 25 years, 90% of people with type 1 diabetes would develop some form of retinopathy. But that retinopathy is mainly the background level, so it doesn't require treatment and doesn't always progress. About 30% of people with type 1 diabetes would have a referable level of retinopathy after 25 years. For type 2 diabetes, it's slightly less. It's 70% after 25 years would have some form of retinopathy. But again, this is of the background level. And 20% would develop a referable level of retinopathy. For the other risk factors for diabetic retinopathy, it's blood glucose. So here we've got HbA1c in old money, so these are in percentages. Researchers, we're still in percentages. We haven't fully taken on the millimoles per mole yet. So if your HbA1c is less than 7%, then almost 20% would have some form of retinopathy. But only 3.1 or 3.6% would have proliferative retinopathy or diabetic macular edema, which is what this stands for here. Once HbA1c goes up to 9%, then 51% would have some form of retinopathy, with 11% having proliferative retinopathy and 12% having diabetic macular edema. For blood pressure, there's little change in the any retinopathy, but the biggest change for higher blood pressure is in the development of the sight-threatening forms of retinopathy. So you can see here, for those with the lower level of blood pressure, only 4.2 would have proliferative retinopathy, but 12% would in the higher. This increases 12% in the higher category. For cholesterol, we didn't see that much difference in any retinopathy or the pre-proliferative retinopathy, but for diabetic macular edema, there was a slight difference, and this is because this is the fatty deposits leaking out into the eye. So it's linked in that way. So if you do go on to develop sight-threatening retinopathy, there are things that can be done by your ophthalmology team to help you not lose vision. So the treatment that's been around for the longest, since 1950s, I think it is laser photocoagulation. This is the mainstay treatment for proliferative eye disease. It's a laser beam that goes into the eye. It seals the leaking vessels, reduces regrowth of new vessels, and regresses new vessels that have already grown. And it does this because it is a laser burn on the eye, so it's destroying the retina area that it touches. It's a really small beam, so it doesn't destroy too much. But for ophthalmologists, it's a really fine balancing act between giving enough laser treatment so that it stops the active retinopathy that's going on, but not so much that it affects your vision. So it's a fine balancing act for them. And they would do this over a number of different appointments to make sure that they can check how the retinopathy is developing or reacting to it. The newest treatments that we have now are anti-VEGF treatments. So VEGF is vascular endothelial growth factor, and this it's a hormone that promotes the growth of new vessels. So applying some anti-VEGF treatment would slow the leakage of the vessels, and it would also help regress and stop new growth. So anti-VEGF treatments are used in maculopathy, but also can be used in combination with laser therapy for proliferative retinopathy. And these are injections into the eye, which everybody hates the thought of, but I have been told that it's not as bad as you think it's going to be. We've then got steroid injections. So these are used then to reduce the inflammation in the eye and reduces the amount of exudate, so the fatty deposits leaking out. And then finally, if you still are after having a lot of laser treatment, if you're still having issues and there's still bleeding or new vessels growing or there's scar tissues formed, they would do a vitrectomy, which is a little surgery that removes the vitreous gel in the eye, and it takes out all the new vessels and the scar tissue and everything else. As people with diabetes, they are unfortunately at higher risk of other eye conditions as well. It's not caused by the diabetes, but these conditions are more prevalent. So it's really important, as well as attending your eye screening, that you're also going to see your opticians on a regular basis, because you're at increased risk of refractive error, so you'll need glasses. Diplopia, which is double vision. So this is caused by damage to the nerves in the eye that are responsible for the eye's movement. Increased risk of cataract, so this is clouding of the lens. And people with diabetes tend to get these earlier than the rest of the population. And glaucoma, which is increased pressure in the eye, and that damages the optic disc. So my final slide is take-home messages. I think the most important point to emphasise here is that sight loss and blindness due to diabetes isn't inevitable. You're not all going to lose your sight. In England and Wales, diabetic retinopathy used to be the leading cause of blindness in the working age population. Since we've introduced screening, it isn't any longer. It's something else. Hereditary retinal disorders have now overtaken it. And in Wales, we've reduced the blindness rates by 50% since we've introduced screening. So it's not just screening, because we've got better treatments now for retinopathy, and there's also improvements in diabetes management as well, which all play a part, but screening really does work, it helps. If retinopathy does develop, there are things you can do to make it get better, make the situation better and make it regress. You can improve your blood glucose management and blood pressure management. They are really important. It's also really important to remember that if retinopathy does progress to the sight-threatening levels, there is treatment out there. There are treatment options available. And the earlier we see the retinopathy, the sight-threatening lesions, the better the visual outcomes are for people. It's really important as well to remember that genetics would play a really important role. We're really not sure what the genes are or how it all works at the moment. But we have seen that some people with low HbA1c, they've always had a low HbA1c, but they can still develop retinopathy. And there are people then who have always had high HbA1cs, and they don't develop retinopathy. And we really don't understand how that happens. And also, it's not your fault. We know that you're trying the best you can to manage this 24/7 condition. Retinopathy isn't a punishment, although it can be seen as one. But please attend your screening. Please go to your opticians and then talk to your diabetes team to get more advice. And that's it.
Brilliant. Thank you, Becky. That was fantastic. We have so many questions.
As always, you're super, super popular.
I think most of the questions we're going to have to answer in the podcast because we're already running over a little bit, but we'll just ask 2 questions. So I'll let Beth do the first one.
So the first one was, if you experience changes to your vision, which you think might be related to your diabetes, who should you go to for help first? Your optician, or to the hospital, or the diabetes team, or the diabetes nurse? What would you say?
So it depends on what the changes are. So if you are noticing dark spots or flashing lights, they are indicative of something going wrong, and you should probably go to the hospital eye casualty to get those checked out. If it's slight fluctuations, you're not sure, you don't want to go to the hospital, then your opticians are usually pretty good at, they can
signposting or
graphs, yes, yeah, and they can have a look. Your GP can't usually see what's going on. They don't tend to have the retinal cameras or the equipment, so it's not the best place. But yeah, opticians, eye casualty, maybe even phone up the screening service to see if you can get an earlier appointment.
Yeah, that's a good idea, actually. I think as a DSN, we would just do the same. I mean, we can't look at eyes and things either, so we would do the same, wouldn't we, Amanda?
Yeah. So next question. When my DD, I'm guessing that stands for
Darling daughter.
Her vision, has high blood sugar levels. Her vision goes blurry and it comes back to normal after a while. Does this cause problems long term?
So this is the high glucose affecting the lens. So this is refractive errors and things like this. I mean, she may need glasses in the future, but it isn't anything to be really concerned about.
Brilliant. Oh, well, thank you so much. Everyone's really enjoyed your session. There is where you can see all the questions coming through. So we will ask Becky all of those questions and get them recorded, like we said. Thank you so much. We're not letting Becky go away. She will answer all of them.
Definitely.